Welcome to Ask, Advise, Refer, brief interventions for assisting patients with quitting smoking.
This program is divided into three major sections, the first one being epidemiology of tobacco use, the second one being addiction to nicotine, and the third one being how to change a patient's behavior. This module focuses on the epidemiology of tobacco use and provides an overview of adverse health consequences associated with tobacco use. As the former U.S. Surgeon General C. Everett Koop noted in 1982, cigarette smoking is the chief single avoidable cause of death in our society and the most important public health issue of our time. The first Surgeon General's report on smoking was published in 1964. Since this time, 29 Surgeon General's reports have summarized the conclusive evidence from biologic, epidemiologic, behavioral, and pharmacologic studies that tobacco use is detrimental to health. While users of non-cigarette forms of tobacco often believe these products are safe, it's important for clinicians to convey to their patients that all forms of tobacco are harmful. As the death toll continues to rise, public health advocates continue to work towards identifying effective ways to prevent the onset of tobacco use and to help patients to cease use of all tobacco products. This graph demonstrates trends in smoking among adults in the U.S. between 1955 and 2009. Since 1990, the smoking prevalence among men and women has experienced only a slight decline compared to previous decades, highlighting a need for enhanced tobacco control efforts. In 2009, results of the National Health Interview Survey indicated that approximately 46.6 million adults of the U.S. population were current smokers. Of these, 78.1% smoke every day and 21.9% smoke some days. More men than women were current smokers. An estimated 70% of all smokers wanted to quit completely, and in 2008, 45.3% of current smokers reported they had stopped smoking for more than one day during the past 12 months because they were trying to quit. In 2008, an estimated 48.1 million adults were former smokers, representing 51.1% of persons who had ever smoked. This slide right here just demonstrates where Arkansas currently sits among smoking in the United States. As you can see, we do have a high prevalence of smoking. Historically, public health efforts to reduce tobacco-related morbidity and mortality have faced strong opposition. The biggest opponent to tobacco control efforts is the tobacco industry itself. Most states fail to spend even the minimum amount recommended by the CDC for expenditures on tobacco control. Yet over the past decade, the tobacco industry has dramatically increased its promotional spending. From 1998 to 2006, their spending increased by more than 85%. For every $1 spent by the states on tobacco control initiatives, it is estimated that the tobacco industry spends nearly $25 to market its products. Tobacco smoke, which is inhaled either directly or as secondhand smoke, contains an estimated 4,800 compounds. The majority of the compounds are present in the particulate phase, suspended in tobacco smoke. Based on a classification system by the International Agency for Research on Cancer, cigarette smoke contains more than 11 known human carcinogens, 7 probable human carcinogens, and 49 animal carcinogens that possibly are also carcinogenic in humans. Cigarette smoking is the primary known preventable cause of premature death in the U.S. Each year, nearly 500,000 Americans die from cigarette smoking. 1 of every 5 deaths in the U.S. is smoking-related. This number far surpasses the combined death toll due to alcohol, car accidents, suicides, homicides, HIV disease, and illicit drug use. The average numbers of years lost because of smoking for females and male smokers are as follows. Males is 13.2 years, and females is 14.5 years. A total of 443,595 annual deaths due to cigarette smoking reported by the CDC. The economic costs to society associated with smoking are enormous. Grand total annual smoking attributable economic costs in the United States is approximately $194 billion, of which $96.7 billion are due to healthcare expenditures and $97.6 billion due to lost productivity costs. Overall, federal state Medicaid programs lost $30.9 billion, and Medicare loses $18.9 billion annually due to smoking. For each pack of cigarettes sold, societal costs are $10.28, nearly double the average retail cost of a pack of cigarettes at $5.51. Strong tobacco control programs can reduce the prevalence of smoking, save lives, and also substantially impact healthcare expenditures. In California, the tobacco control program was associated with an estimated $86 billion reduction in the total healthcare cost between 1989 and 2004. That right there is a pretty strong return on investment. In 2004, the Surgeon General published a comprehensive report detailing the health consequences of smoking. 4 major conclusions of the report are as follows. Smoking harms nearly every organ of the body, causing many diseases and reducing the health of smokers in general. Quitting smoking has immediate as well as long-term benefits, reducing risk for disease caused by smoking and improved health in general. Thirdly, smoking cigarettes with lower machine yields of tar and nicotine provides no clear benefit to health. And finally, the list of diseases caused by smoking has been expanded. Smoking remains the leading cause of preventable death and has negative impacts on people at all stages of life. It harms unborn baby, infants, children, adolescents, adults, and seniors. There are many forms of tobacco available in the U.S. These include cigarettes, pipes, cigars, clove cigarettes, hookah, smokeless tobacco, and electronic cigarettes. Several of these forms, such as hookah and electronic cigarettes, have attained increased popularity in recent years. These will be addressed in the following slides. E-cigarettes are battery-operated devices that generally contain cartridges filled with nicotine, flavor, and other chemicals. These electronic cigarettes turn nicotine and other chemicals into a vapor that is inhaled by the user. These products, which are readily available online and in shopping malls, do not contain health warnings that are comparable to conventional cigarettes or FDA-approved nicotine replacement therapy products. They are also available in different flavors, such as chocolate mint, which may appeal to the youth. Public health experts are concerned that electronic cigarettes could increase nicotine addiction and tobacco use in young people. In addition to the cosmetic concerns, the use of smokeless tobacco is associated with numerous adverse health effects, including the following. Things like periodontal effects. This can include gingival recession, bone attachment loss, dental caries, oral leukoplakia, cancers which can include oral cancer and pharyngeal cancer. As noted previously, approximately 50,000 people die annually in the United States due to secondhand smoke exposure. Despite the tobacco industry's efforts to cast doubt on the link between secondhand smoke and health risk, few scientists and clinicians will deny that secondhand smoke is harmful. Major conclusions of the 2006 Surgeon General's report are as follows. Secondhand smoke causes premature death and diseases in children and adults who do not smoke. Children exposed to secondhand smoke are at an increased risk for sudden infant death syndrome, acute respiratory infections, ear problems, and more severe asthma. Smoking by parents causes respiratory symptoms and slows lung growth in their children. Exposures of adults to secondhand smoke has immediate adverse effects on the cardiovascular system and causes coronary heart disease and lung cancer. The scientific evidence indicates that there is no risk-free level exposure to secondhand smoke. Many millions of Americans, both children and adults, are still exposed to secondhand smoke in their homes and workplace despite substantial progress in tobacco control. Eliminating smoking in indoor spaces fully protects non-smokers from exposure to secondhand smoke. Separating smokers from non-smokers, cleaning the air, and ventilating buildings cannot eliminate exposure of non-smokers to secondhand smoke. This slide right here shows how much money a person can earn if they do not spend their money on cigarettes. And this slide just shows over a 50-year period if a person invested the money per pack that they were purchasing. Perhaps one of the greatest tobacco studies of all time is a prospective cohort of British male doctors. This study was conducted by Oxford University professor Richard Dahl, a leading cancer epidemiologist who more than 50 years first reported that smoking causes lung cancer. Recent findings show a clear picture of the risk associated with smoking. Dahl and colleagues compared the hazards of cigarette smoking in men who formed their smoking habits at different periods, and the extent of the reduction in risk when cigarette smoking was stopped at different ages. Quitting at ages 30, 40, 50, and 60 resulted in a 10, 9, 6, and 3 years of life gain respectively. On average, cigarette smokers die approximately 10 years younger than do non-smokers, and of those who continue smoking, at least half will eventually die to a tobacco-related disease. Persons who quit before age 35 add an average of 10 years of life and have a life expectancy similar to men who have never smoked. In addition to losing years of life due to smoking, a 26-year prospective study of smoking in midlife showed a dose-dependent reduction in the health-related quality of life in old age among men. Never smokers live longer than heavy smokers, and their extra years of age are of higher quality. The 1990 Surgeon General's report on the health benefits of smoking cessation outlines the numerous substantial health benefits occurred when the patient quit smoking. As you can notice, there's different benefits that occurs from a time a patient quits smoking, as early as 2 weeks to 3 months and as later as 15 years. Tobacco dependence is a chronic condition that requires a two-pronged approach for maximal treatment effectiveness. Prolonged tobacco use results in tobacco dependence, which is characterized as a physiological dependence and behavioral habit of using smoking. Addiction can be treated with FDA-approved medications for smoking cessation, and the behavioral habit can be treated through behavioral change programs such as counseling and group or online cessation programs. The next several slides describes the physiological properties of nicotine and its impact on the body. Many people believe that addiction is a result of weakness in character and an inability to change one's behaviors. But is it really this simple? Research contradicts this position. Nicotine addiction is a form of chronic brain disease resulting from alteration in brain chemistry. Dr. Alan Lechner, the former director of the National Institute on Drug Abuse, simply defines drug addiction as compulsive use without medical purpose in the face of negative consequences. But how does human behavior fit into this equation? Many smokers believe that smoking, dipping, chewing is simply a bad habit. Research has shown that nicotine addiction is a chronic condition, one with a biological basis. Nicotine stimulates the release of brain neurotransmitters, including dopamine, which activates the dopamine reward pathway. This induces a feeling of pleasure, which reinforces repeat administration of the drug. With chronic administration, tolerance to the behavioral and cardiovascular effects of nicotine develops over the course of the day. Tobacco users regain sensitivity to the effects of nicotine after overnight abstinence from smoking. When tobacco users abruptly discontinue nicotine, they experience symptoms of withdrawal. These withdrawal symptoms serve as a powerful stimulus to repeat nicotine administration. When nicotine is discontinued abruptly, the following withdrawal symptoms develop, such as irritability, frustration, anger, anxiety, difficulty concentrating, restlessness and being impatient, depressed mood, insomnia, impaired performance, increased appetite with increased weight gain, and cravings. Tobacco users usually experience a strong desire or cravings for tobacco. In general, withdrawal symptoms manifest within the first 1 to 2 days, peak within the first week, and gradually dissipate over the next 2 to 4 weeks. Strong cravings for tobacco may present for months to years after cessation. Tobacco users tend to carefully titrate or regulate their tobacco intake to maintain a relatively constant level of nicotine in the body in order to prevent withdrawal symptoms, maintain pleasure, and modulate their mood. Currently, 5 formulations of nicotine replacement therapy and 2 non-nicotine agents have FDA approvals as aid for smoking cessation. Medications that are available without a prescription include the nicotine gum, the lozenge, and the transdermal patch. Medications available only with a prescription are the nicotine nasal spray, nicotine inhaler, sustained-release bupropion, and varenicline. One formulation of the generic transdermal patch is also available with a prescription. The clinical practice guidelines state that pregnant smokers should be encouraged to quit without medication based on insufficient evidence of effectiveness and hypothetical concerns with safety. Pregnant smokers should be offered person-to-person psychosocial interventions that exceed minimal advice to quit. The FDA has classified varenicline as a pregnancy Category C drug. They have reclassified Wellbutrin as a pregnancy Category C drug, and they also have classified other nicotine formulations as a pregnancy Category D drug. As noted previously, pharmacotherapy is not recommended for use in smokeless tobacco users. individuals smoking fewer than 10 cigarettes per day, or adolescents because of insufficient evidence of effectiveness. These populations tend to be excluded in randomized controlled trials, and therefore there is limited data available. Non-prescription NRT cells are restricted to adults greater than or equal to 18 years of age, and use of NRT use in minors requires a prescription. For each of these special populations, the recommended treatment is behavioral counseling. The rationale for using NRT in tobacco cessation includes the following. It reduces physical withdrawal symptoms associated with nicotine cessation. It eliminates the immediate reinforcing efforts of nicotine that is rapidly absorbed via tobacco smoke, and it allows the patient to focus on the behavioral and psychosocial aspects of tobacco cessation. NRT use significantly improves the success rates of smoking cessation. Advantages of NRT include the following. Patients are not exposed to the carcinogens and other toxic compounds found in tobacco and tobacco smoke, and it also provides lower, slower, and less variable plasma nicotine concentrations than do cigarettes, which reduces the behavioral reinforcing effects of smoking. The nicotine gum is a resin complex of nicotine and polyacrylate and a sugar-free chewing gum base. The original flavor gum has a distinct tobacco-like peppery taste. However, newer, softer-to-chew formulations have been available in a variety of flavors. All gum formulations contain buffering agents to increase the salivary pH, thereby enhancing the buccal absorption of nicotine. A few counseling points for the nicotine gum are as follows. They need to chew until a tingling sensation is felt and has a peppery taste, then place the gum between the gum and cheek. When the taste or sensation is gone, resume chewing. They need to repeat this for 30 minutes and be sure they do not eat or drink within 15 minutes of using. The nicotine polyacrylics is a resin complex of nicotine and polyacrylate in a sugar-free mint or cherry-flavored lozenges. The lozenge is meant to be consumed like hard candy or other medicinal lozenges. Because the nicotine lozenges dissolve completely, it delivers approximately 25% more nicotine than does an equivalent dose of nicotine gum. Like in nicotine gum, the lozenge also contains buffering agents to increase salivary pH, thereby enhancing buccal absorption of the nicotine. The Nicorette mini lozenge results in spring of 2010 dissolves up to 3 times more rapidly than other nicotine lozenges, but does work more rapidly in alleviating cravings. Marketing materials suggest that situational cravings can be alleviated in 5 minutes using the 4 milligram lozenge. A few counseling points for the lozenge are as follows. The patient needs to suck on the lozenge until it is completely dissolved. The patient do not need to break, crush, or chew the lozenge, and they should not eat or drink within 15 minutes of using. Transdermal nicotine delivery systems consist of an impermeable surface layer, a nicotine reservoir, an adhesive layer, and a removable protective liner. The technology for delivery of nicotine across the skin varies by manufacturer. Nicoderm uses a rate controlling membrane. The generic patches use drug dispersion type systems whereby release of nicotine is controlled by diffusion of the drug across an adhesive layer. While the transdermal delivery technology varies by manufacturer, nicotine is well absorbed across the skin. Here goes some counseling points for the nicotine patch. The patient needs to place it on the chest, back, abdomen, or upper arm. The patient also needs to use a different site each time. Also, the patient does not need to cut the patch. Nicotrol NS is an aqueous solution of nicotine available in a metered spray pump for administration to the nasal mucosa. Each actuation delivers a metered 50 microliter spray containing 0.5 milligrams of nicotine. Each bottle contains approximately 100 doses, or 200 sprays, or about a 1-week supply. Nicotine is absorbed rapidly, and plasma nicotine concentrations attained via the nasal spray are comparable to those achieved by smoking. The nasal spray has a faster onset of action compared to the gum, patch, or the inhaler. Some counseling points for the nasal spray include the patient needs a prime inhaler with 6 to 8 pumps before first use, or prime with 1 to 2 pumps if it's not used within the past 24 hours. Finally, the patient also needs to blow the nose before use. The Nicotrol inhaler consists of a mouthpiece and a plastic cartridge delivering 4 milligrams of nicotine as an inhaled vapor from a porous plug that contains 10 milligrams of nicotine and 1 milligram of menthol. Menthol is added to decrease the irritant effects of nicotine. Given that the usual pack-a-day smoker repeats the hand-to-mouth motion up to 200 times per day, or 73,000 times each year, it is not surprising that many smokers find they miss the physical manipulation of the cigarette and associated behaviors that go with smoking. And the nicotine inhaler was designed to provide nicotine replacement in a manner similar to smoking while addressing the sensory and ritualistic effects important to many smokers. As the patient puffs on the inhaler mouthpiece, buccal nicotine vapor is released and delivers nicotine to the mouth and throat, where it is absorbed through the mucosa. Less than 5% of the nicotine in a dose reaches the lower respiratory tract. With an intensive inhalation regimen, about 4 milligrams of nicotine is delivered, and of that, 2 milligrams is absorbed. Plasma nicotine levels are 50 to 70% lower than those achieved with cigarette smoking, and peak nicotine concentrations occur after 30 minutes compared to 5 minutes after cigarette smoking. Here are some of the counseling points for the nicotine inhaler. First, they need to avoid very deep inhalations because this can cause irritation of the lungs, and only one cartridge will last for approximately 20 minutes of acting puffing. Bupropion sustained-release tablets are an oral antidepressant medication used as a non-nicotine aid to smoking cessation. The same chemical agent that is marketed in Wellbutrin is used to treat depression. Varenicline is a partial agonist selected for the alpha-4 beta-2 nicotine acetylcholic receptor indicated for use as an aid to a smoking cessation treatment. This bar chart summarizes the long-term quit rates observed with the different NRT products, bupropion and varenicline. What this chart does illustrate is that quit rates from each of the methods is approximately twice of its corresponding placebo control arm. However, behavioral counseling should be used in conjunction with all the following therapies. This slide presents the approximate daily cost of treatment for the various pharmacotherapies for cessation. These are estimates based on the recommended initial dosing for each agent. Costs can vary considerably depending on the patient's level of smoking, degree of nicotine dependence, product selection, and need for additional doses of short-acting NRT. As a comparison, the cost for one pack of cigarettes is shown. In general, the daily cost of pharmacotherapy approximates the cost of one pack of cigarettes. For more estimates, refer to the Pharmacologic Product Guide. The second issue that prevents many smokers from quitting successfully is the general lack of preparation and planning on the part of most smokers when they approach quitting, and the subsequent lack of any behavioral change. Fewer than 5% of smokers are successful with this approach. The subsequent failures that the other 95% of smokers encounter reinforces the already held belief by these individuals that they cannot quit or that quitting is possible. Likewise, most smokers underestimate how strong the habit of smoking can be, and the need to make changes in patterns and their routines. They mistakenly view smoking as only an addiction and often think that all they have to do to quit is just wear a patch or use the gum. A more successful approach is to view quitting as a learning process. Every smoker had to teach himself or herself how to smoke. Quitting is then a case of learning how not to smoke. In order to learn anything successfully, one must prepare properly and have a plan. However, most quitters not only do not make changes in their smoking-related behaviors, they don't even understand the need to do so. What behavior changes are we referring to? Smokers smoke more than almost anything else they do. The average smoker takes about 10 puffs on a cigarette and smokes between 20 to 30 cigarettes a day. Therefore, they puff on a cigarette on average 200 to 300 times a day. Smoking becomes unconsciously linked to certain behaviors, situations, and moods. For routine smokers, these behaviors, situations, and moods can automatically prompt the smoker to go on a cigarette, regardless of how little or how much nicotine is in the body. Rather, in order to quit smoking successfully, these links have to be broken. Behavioral counseling helps patients to learn to deal with these situations without the cigarette and how to change patterns and routines so that they are not automatically prompted to smoke. Behavioral programs teach quitters something else they can do or think that is not linked to smoking. For example, an individual might get up after a meal and brush his teeth. In stressful situations, She might do some deep breathing and visualize being on a beach. When out with friends, they could refrain from drinking or go to a location where smoking is not permitted. In all cases, these new behaviors are not connected to smoking, so the quitter is not triggered to want a cigarette. Brief interventions have shown to be effective. When time or logistics do not permit comprehensive tobacco cessation counseling during a patient's visit, clinicians are encouraged to apply brief interventions whereby they ask about the tobacco use, advise tobacco users to quit, and refer patients who are willing to quit to a telephone quit line or other community-based resource for tobacco cessation. Tobacco smoke has the potential to interact with many medications, altering both drug levels and efficacy. Tobacco use can induce early onset of disease and exacerbate existing medical conditions. It is appropriate, if not essential, for all clinicians to assess and document each patient's tobacco use status, preferably at each visit. Asking about tobacco use should be considered to be as important as evaluating vital signs during a routine medical screening and when obtaining a medication history. Clinicians should always ask about tobacco in the same way that they would ask about any other drug. The questions listed in the slide are helpful to obtain information about each patient's tobacco usage. When asking about tobacco use, it is important to make a genuine and sensitive approach, conveying concern for the patient's well-being. A judgmental tone likely will not result in accurate disclosure of tobacco use. It's the clinician's responsibility to assist patients in improving their health. Patients who use tobacco should be strongly advised to quit. At the very least, these patients should be advised to consider quitting. The message should be clear and strong, yet personalized and sensitive. The message must be delivered without judgment, or the clinician will likely waste that teachable moment and potentially alienate his or her patient. Tone and manner should convey a concern for the patient's well-being as well as a commitment to help him or her quit when the patient is ready. The clinician can personalize the message by tying tobacco use to current health or illness, its social and economic costs, the patient's motivation level and readiness to quit, or the impact of tobacco use on children, others in the household, and their environment. For example, if you continue to smoke, your disease will worsen or fail to improve. Using a genuine and sensitive approach that acknowledges the difficulty of what is being requested, the clinician is more likely to move the patient forward in the process of preparing to quit. Most quitters do not know the extent of the behavior change options open to them. Simply informing patients of their choices can be a powerful intervention and can be done in less than a minute. As such, you should compile a list of all smoking cessation programs in your area to distribute to the patients. These options can include, but are not limited to, the healthcare professional with whom you work, local group programs offered by American Cancer Society, the American Lung Association, or community hospitals. Also, all 6 smoking cessation medications offer free behavioral support programming as part of their treatment package. The FDA requires this of all smoking cessation medications. The programming generally consists of a toll-free helpline, written materials, and a website with tailored quitting materials. Even if patients use other behavior change options, it is helpful to have them enroll in a program that comes with their chosen smoking cessation medication. The federal government supports a toll-free national quit line, which is 1-800-QUIT-NOW. This number automatically routes the caller to their state quit line and takes calls for the states that do not yet currently have a quit line. These quit lines have been shown to be effective. In the absence of time or expertise in counseling patients on smoking cessation, you can tell them to call 1-800-QUIT-NOW or other local quit lines or other programs in your community. These brief interventions can be achieved in less than 3 minutes. Tobacco quit lines offer tobacco cessation counseling at no cost to all Americans. They are staffed by trained specialists, and they can offer up to 4 to 6 personalized sessions. These tobacco quit lines also have up to 30% success rates for patients who complete all sessions. In most states, the quit line can refer callers to local programs, provide quitting literature by mail, and or provide individualized telephone counseling. Some states are able to provide multiple counseling sessions. Quit lines have a broad reach and, as noted previously, are recommended as an effective strategy in the 2008 Clinical Practice Guidelines. In summary, then, it is recommended that all clinicians, at a minimum, make a commitment to incorporate brief tobacco interventions and as part of their routine care with all patients. You can successfully intervene in 5 minutes in the context of a regular interaction with the patient. Should even that prove to be impractical, clinicians should ask the patients about tobacco use, advise them to quit, and refer them to other resources for additional assistance. This quote, which comes from Dr. Gro Harlem Brundtland, former Director General of the World Health Organization, is a closing remark in the 2001 Surgeon General's report on women and smoking. It appropriately emphasizes the urgency of the need for clinicians and other healthcare professionals to take a more active role in countering tobacco use. According to Dr. Margaret Chan, Director General of the World Health Organization, reversing this entirely preventable epidemic must now rank as a top priority for public health and for political leaders in every country of the world.